APMPPE. That is a placoid, multifocal placoid epitheliopathy seen in younger patients, young boys. So these are the kind of multifocal lesions that you see. And diffuse inflammation, these are the two very common causes. VKH is now commonly seen in our country. And this presents as a pan-uveitis always. So whenever you see a patient with a bilateral pan-uveitis, this is a diffuse inflammation. The entire eye is inflamed. So the two entities, the common entities that should come to your mind are VKH, Vogt-Koyanagi-Harada syndrome, and sympathetic ophthalmitis if the patient gives a history of trauma. So the diagnosis of chororetinal lesions, the first thing is a careful clinical examination. Most times the investigations don't really add too much to it. A clinical examination is extremely important. And then tailored investigations. Once you've thought of these entities in your mind, then you tailor your investigations to reach a diagnosis. So as I mentioned, this is the algorithm. Like if you have a focal lesion, and if there's a lot of vitritis, you think of toxoplasma. And if you have less vitritis, you think of serpiginous choroiditis. These are focal lesions. And if you have multifocal lesions with no vitritis, then again this is AMPPE. And if you have vitritis, then it could either be sarcoid or tuberculosis. Tuberculosis and sarcoid can present both as multifocal and focal lesions. So now we'll go on to certain common entities that we see in our clinical practice. Most common being, as you all know, is tuberculosis. So tubercular uveitis is still, in spite of so many diagnostic equipment available to us, diagnostic tests available to us, is still an enigma. So it's not only an enigma, it's actually a riddle which is wrapped in a mystery inside an enigma. No one is able to for sure diagnose tubercular uveitis even today. So why is it an enigma? Because tubercular uveitis presents with a wide spectrum of presentations. It's called a great mimicker. And it may occur either in association with clinically apparent pulmonary tuberculosis, or it may be in isolation. There may be no clinical or lab evidence of a pulmonary infection. So it becomes difficult to diagnose this. Also, there are variable diagnostic criteria, and most often the diagnosis that we make is always a presumptive diagnosis. We always keep a high degree of clinical suspicion. And also, paradoxical responses to treatments are known, which further complicate the picture. So uveitis is the most common ocular manifestation. It could be anterior, posterior, intermediate, or pan-uveitis. And choroid is the most common initial site of a tubercular infection. And the important thing to note is the spectrum of intraocular tuberculosis is still evolving. There's a new entity called serpiginous choroiditis in tuberculosis. Now, that is a new entity which has come up, which has been linked to tuberculosis. So every day we are discovering newer choroiditis, which is being linked to tubercular bacteria, bacilli. So the anterior uveitis in tuberculosis could be acute or chronic granulomatous anterior uveitis. It's typically granulomatous, but most often you'll even see non-granulomatous picture. So this is not an absolute thing. It'll be a recurrent iridocyclitis. You treat the patient with steroids, he'll respond, but then again he'll come back a few months later again with a recurrent iridocyclitis. So a patient who's coming to you with recurrent episodes of iridocyclitis, you have to keep a very high suspicion for tuberculosis. The syneci are broad-based. The kind of syneci here, the base of the syneci is really broad, and these are the typical syneci that have been described. And when the patient presents with anterior uveitis, there's always some anterior vitritis as well. Intermediate uveitis, tuberculosis can also present as intermediate uveitis, and in fact, the most common cause of intermediate uveitis in India is tuberculosis. And now coming to the posterior part, which we have to deal with. So tuberculosis can present with choroidal tubercles, a choroidal tuberculoma, a subretinal abscess, or like I mentioned, a serpiginous-like choroiditis. So choroidal tubercles are multiple small nodules which are smaller in size than the disc. Typically, there is no vitreous inflammation when you see tubercles or tuberculomas, and this is due to hematogenous spread in miliary tuberculosis. So when you see these tubercles, choroidal tubercles, you always suspect that the patient has miliary tuberculosis. These generally respond well to ATT and take 3 to 4 months to heal. So these are what typical choroidal tubercles look like. When you see such lesions, small circumscribed choroidal lesions, always keep the suspicion of tuberculosis in mind. Choroidal tuberculomas are large yellow subretinal mass with surrounding exudative retinal detachment, 2 to 14 millimeters in size, and there may be overlying hemorrhages also. Like this is a choroidal tuberculoma, this is a tuberculoma. So when you see such lesions in the Indian subcontinent, when you see such circumscribed choroidal lesions, so the first diagnosis you think of is tuberculosis. Of course, ocular tumors can also sometimes present like this, and a B scan would help you to differentiate. Tuberculomas can often be the first clue to diagnose systemic disease. A patient comes to you with maybe fever or maybe blurring of vision, and when you see a lesion like this, you can ask the patient to go in for subsequent investigations like an X-ray chest or a CT thorax or an MRI of the brain, and you'll generally see this tuberculoma maybe in the brain also or somewhere else. So like this was a patient who came to me with a history of fever and a mild blurring of vision. This was a tuberculoma. When we got an MRI done, we saw tuberculomas studded in the brain. So the patient was diagnosed by just a fundus examination. A very fulminant infection can present as a subretinal abscess, which is more elevated, there is more exudation around it, there may be hemorrhages around it. So when you see such a presentation, it's called an abscess. The next condition is a serpiginous-like choroiditis. We'll be discussing serpiginous choroiditis in the subsequent talk. So serpiginous lesions generally start near the disc and then they keep moving on like a serpent. You know, the inflammation, the second patch starts next to it and the third patch starts next to it. They keep creeping forward. But the important point to note in tuberculosis is that the serpiginous choroiditis in tuberculosis is a multifocal serpiginous choroiditis. The lesions may not be connected to each other. They may be multifocal all over the retina. And they may be in the periphery also, as opposed to the serpiginous choroiditis, which is not linked to tuberculosis, where the lesions are peripapillary and macular. And in this case, your patient has to be started on ATT and corticosteroids. So it's important to clinically differentiate between serpiginous choroiditis in tuberculosis and serpiginous choroiditis without tuberculosis, because in this case, we'll be giving ATT and no immunosuppressives, while in a serpiginous choroiditis, corticosteroids and immunosuppressives are given. Also, as we all know, Eales disease or retinal vasculitis is very common. So when you see very severe vasculitis in a patient, when you've ruled out all the other causes, you think of tubercular etiologies. And generally, you'll see healed patches of choroiditis along these areas of vasculitis. So that is a clue that you're dealing with a tubercular infection. So like I said, tubercular chororetinitis has a wide variation of presentation. There are no uniform diagnostic criteria. And an intractable disease course with multiple recurrences or non-specific treatment is a clue, which would suggest that the patient has a tubercular etiology. So we all know the PPD skin test, where 5 tubercular units are given to raise a wheal. A positive Montus test in the Indian subcontinent doesn't really rule in tuberculosis, because as we know, most of us have been vaccinated in our childhood, so we would have a positive reaction. Also, if a patient is really immunocompromised, he will not show a positive reaction. Then this test called quantiferon gold, which is now being talked about a lot. Quantiferon gold only tells us that the patient has latent tuberculosis. We don't have any test like even the PPD test or the quantiferon gold test. They do not tell you about active infection going on. They only tell you about latent infection. And around 40% of people in India would be having some kind of latent infection. So just to diagnose a patient on the basis of quantiferon or PPD is not correct. You have to keep your clinical diagnosis in mind, and then these would just add to it. These tests are expensive, so they're not really useful. They don't really add too much to your diagnosis. The main diagnosis is clinical. X-ray chest or a CT thorax would show evidence of active or healed tuberculosis. And a PCR, if you take it from the aqueous orbitris, is the most confirmative test. But then again, it's a very sensitive test. Most of the labs are not able to give very correct results. The sampling has to be really perfect. So again, practically PCR, only in certain institutes or institutions where they are used to dealing with this material, you can get it. Otherwise, most often the results are pretty disappointing. So the diagnosis for the guidelines for the diagnosis of intraocular tuberculosis are clinical signs, then investigations, that is if you can directly demonstrate acid-fast bacilli or culture from ocular fluids, and a positive PCR, systemic investigations, and a therapeutic test. So any one of these clinical signs, along with any one of these two, is a confirmatory for tuberculosis. So most often we only get these clinical signs. To demonstrate or culture tubercular bacilli from ocular fluids is virtually impossible. We hardly do it. PCR also, I said, to get a positive PCR, very difficult with labs. So most of the time we only have to rely on these clinical signs. So these clinical signs plus systemic investigations is considered presumed ocular tuberculosis. So most of the time when we see a patient, we always presume he has tuberculosis. We can never have a sure diagnosis. So whenever we always say it's a presumed tuberculosis. Treatment is the standard, this is the standard ATT treatment. The important point to note is the treatment has to be continued for more than 9 months or more at least for these lesions to resolve. Not 6 months. And it can be extended if needed till all the tubercles have resolved. And corticosteroids generally have to be added for these big tuberculomas to resolve. So once you start the patient on ATT, you can also add steroids very safely. Most tubercles respond very well to ATT, as you see here. This was after 2 months. You see the lesion has regressed on ATT and steroids. Here also you see the lesion getting demarcated. Large tuberculoma, which has healed in 6 months. So, as you see, all tuberculomas healed. But this was a patient who came to us, like the patient I'd showed you before. He came with a vision of 6/6. He just had a mild transient blurring as because of the disc, because of the papilledema that you see. His vision was 6/6 otherwise. So this patient, I showed you the MRI. He had tuberculomas in the brain and he was started on ATT. We saw him after a month and his vision had dropped from 6/6 to 6/18. This was before ATT. This is 3 weeks after. So you see the lesion had increased after ATT. Was it something else? Were we looking at something else? Was it not a choroidal? Was it not a tuberculoma? You see the exudation around the lesion has increased. There are hard exudates going right till the fovea. So what was this? This is called a paradoxical reaction. So many times, patients can present with a paradoxical increase in the lesion in the first 2 months, maybe first 1 or 2 months. When you start the ATT, the lesion can increase in size, and this is called a paradoxical reaction. So when such a thing happens, again, you have to keep a very high index of clinical suspicion. When such a thing happens, you have to add steroids to this, and you see, once we added steroids, the lesion started regressing, and then scarred off. Finally, and the patient regained 6/6 vision. So this is another entity that we have to be aware about. This was a patient treatment. This was before with ATT, and this is after we started the steroids. So don't be afraid of starting steroids in these patients. It is necessary most times. Another paradoxical reaction, patient before ATT, you see this large abscess. After ATT, the lesion just flared up, but then after that, again, it resolved. So paradoxical reaction is worsening of pre-existing tubercular lesions or development of new ones after initiation of ATT. It normally develops 3 to 12 weeks after start of ATT, and it's a delayed type of hypersensitivity reaction. Once you see a paradoxical reaction, you have to rule out poor compliance, of course. You have to rule out drug resistance. You have to rule out some other underlying conditions which could mimic it. But once you're sure of your clinical diagnosis, then you just stick to your treatment. So clinical judgment, regular follow-up, and guarded reassurance of the patient is required to manage these paradoxical reaction, and definite role of steroid therapy is there. So thanks. With that, I conclude my talk on tuberculomas.